Good morning. My name is Eve Lossman, and I'd like to welcome you to our fifth webinar in a series of provider education sessions focused on safe prescribing practices. Today, we're going to be talking about effective conversations, specifically around tapering and deprescribing of opioids, and then just pain management in general. On behalf of University of Michigan's Injury Prevention Center team and our colleagues at MDHHS, I hope that you will find this webinar informative. We have about 90 minutes and we've built in time for Q&A. So please do ask questions in the Q&A section of the webinar. We're really pleased to have a fantastic panel to discuss this topic today. Next slide. I'd like to introduce you to Jillian DiClemente. Those of you who have been coming consistently to our webinars will recognize her from our first session around the CDC updates. She is a pain management clinical pharmacist here at University of Michigan. She's a fountain of knowledge when it comes to opioids, pain management, and patients with challenging circumstances around their pain management. Next, I'd like to introduce you to Chris Frank. He is an associate professor in family medicine here at University of Michigan. He is one of the experts related to pain management and addiction management, working with the OPEN group, the Overdose Prevention Engagement Network. He's also a member of the Opioid Research Institute. I'm your moderator. I'm Eve Lossman. I'm an emergency physician here at U of M, and I'm core faculty at the Injury Prevention Center. Next slide. None of us have any disclosures related to today's topic, except for a passion around having a holistic approach to patient care. As we all know, providers can make an enormous difference when it comes to effective pain management and bending the curve around the opioid epidemic. Next slide, please. As in all of our previous webinars, we do try to take a holistic approach as we consider the topics that we engage in. Next slide. So without further ado, we're going to focus on effective conversations. And next slide. Today, we are going to have a little bit of background about why this is so important, and then we're going to change things a little bit compared to what we've done previously. We are going to have Jillian and Chris turn on their cameras and have a conversation about effective conversations. They have created 4 kind of classic cases. They're going to walk through those cases. They're going to give you some tips about how to approach patients, how to engage them, how to get patients thinking about how they can change their pain management strategies, because of course it's not us imposing it on patients. It's really a shared process. And we're going to focus a little bit on opioid hyperanalgesia. We're going to talk about tapering and deprescribing. We're going to be talking about the role of buprenorphine for pain management, and then a little bit about differentiating the different types of opioid dependence. One more thing for you guys to be aware of in the audience. We have typically had text-heavy slides where you can look at the slides and kind of sort of know what the speaker is going to say. They add a few little caveats, but for the most part, the content is there. Today, we have tried to peel back a little bit the words so that you'll pay attention to the conversation, but be assured that there's a ton of resources that are attached to this presentation. And when you fill out your survey for your CME, you will get all of that information included. So without further ado, next slide. Let me introduce you to Chris Frank. Dr. Frank will start our conversation with a brief background, and then he and Dr. DiClemente will take us through a series of cases. So without further ado, take it away.
Great. Thanks, Eve. Thanks for inviting us. Excited to be here and to talk to you about this topic today. Um, I'll just start with giving a little background about pain, although probably if you're on this call, you might not need this little reminder that pain is one of the most common reasons that people seek medical care. I'm a primary care doctor and an addiction medicine person, so I see people mostly in an outpatient setting now, and I'm sure if there are other clinicians on this call, we all know that pain is one of the most common reasons that people come to see us. In the United States, you know, when we're talking today, we're going to be talking a lot about chronic pain. And one of the things that Jillian and I will be trying to kind of emphasize is the difference between acute and chronic pain, both in sort of how they work, but in how we talk about those issues with patients. But 25% of Americans report suffering from chronic pain. So it's really, really common. It's not something that's isolated to certain specialties or certain clinical settings. It's really everywhere. And it's a really stigmatized condition. When we do big surveys of how patients get treated, we know that there's some groups of patients that in general are not very well treated in the medical system. And in those groups, I see a lot of them. So people with substance use disorders, people with mental health conditions or co-occurring conditions with substance use disorders, people with chronic pain, people with significant obesity, right? Those are kind of some of the big groups that we think of that are stigmatized. And so it makes sense, as chronic pain being as common as it is, that we've tried lots and lots of different ways of helping people, some of which have been helpful and some of which have been not as helpful. And we'll talk about some of those things today. And I know Eve made this slide here, and I think it's an important reminder that, the United States is a bit of an outlier in terms of our approach to chronic pain. And our use of opioids sort of preferentially. And obviously that tide has shifted quite a bit, but we're still way on the one end of the bell-shaped curve in the United States in terms of how much reliance and emphasis we put on using opioids for pain. So maybe next slide. And the first case we're going to talk about today is, I think, one of the most common scenarios that many of us face, which is inheriting patients that are coming to us in whatever clinical setting we're in, already on regimens that maybe we're less than ecstatic about. And one of the reasons that patients with chronic pain get shuffled around in the system is that it can be really difficult to find a home and to find a reliable and consistent source of care. And I think, a lot of times we think of maybe this is something that needs a super specialist person to manage, but there's really no ability for the system to just take patients with chronic pain and shuttle them towards pain management services, so specialized pain clinics. And, I think those of you who follow the news probably know that a lot of the specialized pain management sources or, clinics, they often focus on, frankly, things that get reimbursed. So they often are focused on procedures and other interventions that sometimes work for pain, but don't work for lots of types of pain, especially some of the chronic types of pain that we're going to be talking about today. But this is a picture of a large group of pain clinics that closed. And it's a reminder that there are lots of ways that that we inherit patients who are on higher risk regimens that include opioids or maybe benzodiazepines. And it can happen one patient at a time, or it can happen in these big boluses when clinics shut down or when hospital systems consolidate. So I work as a consultant a lot of the time. So I work for the opioid prevention and engagement network, and so I take call, and we get calls from all over the state, and we get all kinds of things. So people call about opioids and stimulants and co-occurring conditions and post-op pain, pre-op pain, methadone, all kinds of stuff. But the most common call we get is I have this patient who's coming to see me, or I'm seeing them for the first time, and I looked at their medication list and I'm feeling very uncomfortable. So that sometimes is because someone retired. It can be because some clinician moved. And then, like Michigan pain consultants here on the west side of the state, this can be a situation where sometimes 30 or 40,000 patients are dumped into the system. And because it's such a highly stigmatized condition, people can often really struggle to seek care. So maybe we'll start with a case, and then the focus today is really a little less on the mechanistic parts of tapering people, moving their medications around. All of that's important too, and we're happy to talk about any of that. But really, we want to talk about the communication part, because I think that's the most common place for this to break down. It's actually not like that we mess up the dose changes or those kinds of things. It's that sometimes we struggle with the communication aspect. So why don't we go to the next slide, which is the first case. Oh no, I lied. It's not quite the next slide. This is just a reminder that pain management can be difficult to access, and it can be due to lots of different reasons. This slide, I think, does a good job of talking about some stigmatizing behaviors where clinics will close specifically to patients that are on opioids or on high-risk medications or have chronic pain in their problem list. And then there are all kinds of other things that create barriers for people to seek care, including insurance issues and reimbursement. Clinicians, physicians, APPs are often worried about liability or taking on patients who are on high risk regimens. And we'll talk a little bit about how to manage those risks in a way that doesn't leave patients to hang out to dry. And there are also, some significant disparities in how chronic pain affects different groups of patients. And sometimes those barriers are specifically, biases against Medicaid or other groups of patients. It can make it for some people really, really difficult. For everyone, it's difficult to get care for the most part for chronic pain, but for some people, it's almost impossible, and getting high quality care can be really challenging. Next slide. So we're going to talk about 4 cases today, and hopefully Jillian and I will go back and forth a little bit. Please throw any questions or comments into the Q&A. Jillian and I love answering questions and dealing with real world situations. So feel free to throw your hardest things in there. That makes it fun for us. The first case is going to be the one, the really common situation of inheriting a patient on chronic long-term opioid therapy. And then we have 3 more cases. The second one is someone who's already in your practice, but increasing their dose. I think we call it self-directed here, which, someone who's escalating their dose and how to approach that. And then Jillian is going to talk specifically about case 3 and 4, which are around some of the nuances of how we get into these situations where opioids are maybe no longer being helpful for someone, and how to have those discussions about helping patients reassess the approach that they've been taking, possibly for a long time, to see if we can get them better outcomes. And then case 4 is one that I think Jillian sees a lot, and I see fairly often too, which is a situation where someone might be put on higher risk medications like opioids for a specific health crisis, in this case, cancer diagnosis. And then when that health crisis has resolved or gone into remission, sometimes those medications have been continued, and those can sometimes be challenging conversations also. Next slide, please. So this is the first case here. So it's a 60-year-old man seeking a new primary care physician, and he's new to our clinic. And his chief complaint when he fills out the paperwork is that he needs his pain meds refilled. And if we look back at the history, he's had chronic back pain. He's been on opioids for 15 years. He's got a few co-occurring conditions, which are common, like depression, anxiety, has type 2 diabetes, sleep apnea. He's overweight, and also tobacco dependence. And his medication lists is complicated. I can't really ask for people's opinion here, but sometimes I'll give a talk like this, and I'll say, like, so what do you think when you see this medication list? And I won't put words in everyone's mouth, but I can tell you that what most primary care clinicians think when they see this medication list is, ooh, this is not going to be a run-of-the-mill situation. This is going to be a little more challenging. So this person is on morphine, sustained release, 60 milligrams, 3 times a day. They take another form of opioids, a shorter acting opioid, Percocet, so oxycodone, 8 tablets a day. And then they're also using benzodiazepine 3 times a day. And other than that, on their intake paperwork, they don't express any other alcohol or substance use issues, and they say they haven't had any problems with opioids. And this case makes it a bit easier. It says, that you were able to do a records review, and you could see that refill requests were on time, and the PDMP showed that the fill pattern was consistent with what you think is being prescribed, and even urine drug testing that consistent with prescribed meds. So really delivering the message that this patient is taking their medications as prescribed, and they've been on it a long time, and you still look at it and you go, ooh, I don't know if that quite matches what I would like to do. And I'm not sure this is consistent with the recommended guideline approach to nonspecific chronic low back pain in a person with multiple other comorbidities. I will say that we usually don't get that last part in italics. Oftentimes we don't have old records. Maybe we haven't been able to get into the PDMP first because they're still getting registered. Maybe we have the PDMP result, but not their urine drug testing. So it's common to enter these cases, I think, with maybe even less information than this. So let's jump to the next slide. So there are all these things that right at the beginning this situation brings up. And I think as clinicians, we're probably biased to see it from our perspective. And so from the clinician and clinic perspective, I think these situations often can set off a little bit of defensiveness, anxiety, just like a general feeling like, why does everything bad happen to me kind of scenario, even when, we're actually not the focus of the situation. And so oftentimes we're worried about things like, not having enough time to adequately assess the situation. We're worried about the resources this might take. Sometimes we feel uncomfortable with the combination of medications or not knowing exactly how people got to the situation they're at. And sometimes we're worried about how this could disrupt other parts of our practice. And so I think a lot of times clinicians enter these relationships already with a little bit of trepidation, anxiety, and you know, we're very social creatures, and patients pick up on that very easily. That we're already entering the situation in sometimes not the perfect mental state. But I wanted to focus on the other side of this, which is the patient side. Um, I think almost everyone who has been a patient in these situations also has an incredible amount of trepidation and anxiety with these disruptions in care. So people are very concerned that their medications are going to be stopped abruptly, that they're going to be stigmatized, maybe that they can't even find a clinician who's willing to see them, or that when they do find someone, they're not going to take into account their individual situation, but are going to apply some outside guidelines or expectations. And I think, frankly, a lot of us have seen this happen a lot. And I know Jillian talked earlier in the series about the CDC guidelines. And, I think we can all say that we have seen how this goes when it's done poorly, in the sense that, we've seen abrupt discontinuations of opioids and benzodiazepines, and people, essentially just being cut off their medications. And we know that, we know more than we did in 2016. And we know that now that really doesn't go well. Patients really don't do well. They end up in the ER. They end up bouncing between clinicians. There's good evidence of adverse mental health outcomes, including increases in suicidal ideation. So this can be really devastating series of changes for patients. And so, trying to put ourselves in their shoes, really empathizing with their situation, because no one got to this pain regimen, where you're taking long-acting morphine throughout the day, Percocet, 8 tablets throughout the day, a benzodiazepine throughout the day. No one started with that regimen. That was never the intention of whoever started this. So oftentimes in the back of my mind, what I'm thinking is, oh, this is someone who has suffered a lot. And they have gotten to this point over a long period of time. And the idea that we're going to come in and clean house on day one is not only unrealistic, it can be really damaging to the relationship you have with these patients. So I think what happens sometimes is clinicians are anxious. They're a little worried about this. Patients, very anxious. They're worried about it. They're worried about being abandoned. And when these two things combine at those first sets of interactions, it can create an environment that is not really great for very open and honest communication. And so essentially, I think sometimes these first interactions, we're not seeing patients at their best, and sometimes patients aren't seeing us at our best. And so keeping that in mind about how we show up when we're first seeing people, creating safe environment where people can be open, they're not fearful that something dramatic is going to happen. I think, I think that's the best way to approach this. And I will say this as someone who has gotten to an approach like this over many years and trying many other approaches that have not worked as well. So we can only know our own experiences, I guess. But I've seen people do this well, and I've seen lots of us do this not as well. And it's a lot more fun, both for us and for patients. And it feels a lot safer and better when we do it well. So next slide. So I think the first thing to set up for these early interactions is that there's no ticking clock. This is not like a MacGyver where you have to defuse the bomb within 30 minutes the first time. People have gotten to this point over a long period of time, many years. And we know the evidence now is clear that when you try to do dramatic things, like abruptly discontinue opioids, abruptly stop people's benzodiazepines, these have real world negative consequences in terms of both health outcomes, resource utilization, and it just is not good for anyone. So one of the first things we talk about is trying to bring some other pieces of us into the conversation to start working on rapport and building a long-term relationship. Because I mean, everyone who has kids knows this. Like when people are feeling challenged, they often withdraw, right, or put up defenses. And so you're trying to create an environment where people are free to tell you their concerns and how things are working, because that's the only way you're going to get to a place where you can actually make productive changes. So one of the places I often start is around safety, talking about how we can, wow, I see you're on some so you're on some complicated medications. This must be really difficult. I'm sure you've gotten to this over a long period of time. Just coming into this fresh, I want to make sure that we have things as safe as we can for you, where we think about how to think about how your care is going to go going forward. So one of the first things a lot of us start with is around naloxone and naloxone education. It's not as stigmatized as talking to people about their opioids and benzos, and you can often couch it in ways that show that you care, and essentially saying, like, I don't know what happens. I don't know if you ever have problems with these medications, but the guidelines now tell us that everyone who's on opioids and benzodiazepines should have a prescription for naloxone at home, just in case there's a time where they have a complication from their opioids, so that a family member could help reverse an overdose or something like that. This is just like, if we're having people with allergies might have an EpiPen, everyone who uses chronic opioids should have naloxone. And then maybe a more controversial aspect of this is, I think it's often not that helpful to try to make changes the first time you're meeting people. Most patients who have taken opioids for a long time and benzos for a long time have developed both like physical attachments to the medications in terms of tolerance or withdrawal, but also emotional attachments. And these are often a regimented part of people's day, especially people who are taking multiple doses of medications throughout the day, like this patient. So sometimes just taking that off the table, like, oh, we don't need to make big changes to your medications right now. Why don't we get to know each other? We'll make sure we have the safety stuff in place. And then I'm going to start to get to know you over time, and we can keep talking about what your goals are. And so first visits don't have to be like marathon sessions of digging into people's childhood and their adverse childhood experiences that, or trauma that in the past led to some of the issues that are now being treated with opioids. But just reassuring people early on that you're not in an adversarial relationship with them can go a long ways, because most people are very, very fearful and terrified of being abandoned and not being able to refill his medications, because almost always they're going to have physical tolerance and withdrawal if they've taken opioids and benzodiazepines for a long time. So, it's a physiological thing. So like any of us who take opioids for a long time, if we stop them, we're going to withdraw. If we take benzos for a long time, if we stop them, we're going to withdraw. And sometimes those withdrawals can be dangerous. We often use the first early meetings with people also to talk about what non-opioid type things they're using. Not as maybe that we need to add a lot of those things in right at the beginning, but we're planting the seeds in people's minds about other approaches to pain and other than opioids. Sometimes they'll be using some of them, sometimes they won't be. And really, all of this is just a way to start building towards a long-term relationship, because that relationship is what allows you to do some planning in the future that gets people to a little bit safer place. So how about the next slide? So like I mentioned, naloxone is often a good place to start for any high-risk patient. And when you're describing it to people, you don't have to say, your medicines are so crazy that I'm worried that you might die from them. You can just say, you're on opioids, and we recommend having this reversal medication around anytime, because sometimes people can get confused and they might take an extra dose. But especially as people get older, some parts of our body that clear these medications can change. And sometimes we can get sick and our liver or our kidneys can stop working as well, and these medications can build up. So it's important to have a medication around that if someone were to get super sleepy at a time when they were getting sick, they would have a way to safely reverse that medication while they got help. And I think this is a conversation starter that Jillian put in. And I use very similar thing. I'm prescribing this for you because I really care about your safety. This is, just like an EpiPen for someone who has an allergy. We prescribe naloxone for people who might have a bad reaction to an opioid medication or whose body might change over time. And we hope you'll never need to use it, but it's like wearing a seatbelt or having a smoke detector. These are things that we hope we never use, but they're important to be there because these can be serious side effects or adverse events associated with these medications. Next slide. So I just wanted to put down, these are a few reminders for me to talk about different things. You can read it if you want, or you don't have to. But these are some of the things that I think Jillian and I think about when we're seeing patients in these situations for the first time. And I've mentioned a couple of them, but I have like a mental checklist that I'm going through. And some of them are in the like what I'm worried about, and some of them are in the what do I think patients are worried about, and how am I going to elicit that information from them. And we mentioned the risks of abrupt discontinuation of controlled substances. Like I said, we know a lot more about this now, and a number of our professional organizations have put out recommendations and guidelines that really emphasize this. So, for example, American Society of Addiction Medicine has published some guidelines recommending against the abrupt discontinuation of both opioids and benzodiazepines because of the risk of adverse events. And so there is some like professional guidance around this that reinforces this approach that, we don't have to come in swinging and talking about how quickly we're going to stop people's medications because that discussion typically doesn't go well. The importance of the prescription drug monitoring program. In this case, I think we said, well, we already had that, but always a good practice to look these things up anytime you're seeing someone in a clinical setting with controlled substances. PDMP, I remember a pre-PDMP world, and it was terrible. I never knew exactly what people were getting and who they were getting it from. And while our PDMP is not perfect, there are still patients who fall through the cracks. Some of the groups that I think of are, people in methadone maintenance programs fall through the cracks. Sometimes people who get medications out of state or are snowbirds and are moving around can fall through the cracks. But for most patients now, we can really get a good idea of how often are people filling their medications, who's been prescribing it in the past? Is it mostly from one pharmacy? Is it mostly from one clinician, or is it from a bunch of clinicians? And that is really important to figure out where we fit in the treatment environment. Obviously, we always love it when someone comes to us and they've only been receiving medications from one person. That makes it easier, but that's not always the way it is. And so before we get involved, we always want to understand who's the responsible clinician for all the different classes of medications that someone's taking. I just wanted to mention the role of urine drug testing, because this is actually a question that we get a lot. I'm seeing this new patient, they're on this regimen. When they come to me the first time, actually the question we get is, should I stop their benzos right away, or should I stop their opioids right away? That's the typical question. And I'm often like, well, maybe first day is not the time to have that discussion. But I think urine drug testing is an interesting one, because I think our instinct as clinicians is to want to know, right? We want to know what people are taking. I think the downside of urine drug testing sometimes is that it can create, if it's not done well, it can create an adversarial or low trust relationship, where the person is saying like, look, this is what I'm taking. And you're saying, well, I'd like to test anyways, right? And the person is saying, well, I'm telling you what I'm taking. Like, this is what I'm telling you. So I often delay urine drug testing until we're headed to a better relationship. And I think now, especially when our drug supply is more complicated and fraught than ever, especially for patients who are taking illicit medications, who I see a lot of because of my addiction background, it's a lot easier now because I can say, hey, I want to do urine drug testing because I know you're telling me you're taking cocaine, and I believe you that you're taking cocaine, but there's also other stuff in there. And I think this would be important for both of us to know what's in the drugs you're using. But for patients like this case, where it's a prescribed only medication with regular PDMP fills and checks and records that back it up, I think oftentimes early drug testing can be a relationship killer. I think the other question that we wrote here is, how much history do you need? And this was just my reminder to the crew that maybe you don't always have to take an exhaustive history the first time you see someone. Almost always it's complicated, right? And it's kind of like a first date. If you come in swinging, talking to people about the worst experiences of their life, that's not the recipe for a strong connection. And we know that one of the most positive predictors of retention in treatment and our ability to elicit change and motivational interviewing is really around the relationship. And so prioritizing the relationship over the details of the medical situations seems to work well. And then some of the important patient considerations that I think all of us do focus on in the beginning is trying to assess other barriers to effective pain control. And so, we'd commonly ask about, mental health conditions, anxiety, depression, how people are sleeping, and what their concerns are. What are you hoping to get out of your visit today? And what are you worried about? What are your fears and concerns? Depending on how people are feeling, they may or may not share. But asking those questions in open-ended ways that allow people a chance to share with you, even if they don't share, lets them know that they can share in the future, and I think is an important piece. The last point or two on this case, and then the future cases will be a bit shorter because we'll have covered some of the high level points, is that, the goal is not perfection, because this has happened over a long time. Any small amount of progress towards increasing safety or improvements in function, those are things that we're looking for, because those are little nuggets that we can grasp onto as places to jump off for future visits. We talked about safety, including naloxone. And the last piece I wanted to talk about is documenting these conversations. I mentioned that one of the concerns a lot of people have is around a lot of the concerns that we often have are around liability. And it's important to document these things. And I think people are often worried about this part. And I encourage people to make their own little dot phrases if they're a MyChart, or if they're an Epic user, or any of the other EHRs, that really says, I'm seeing this patient for the first time. They're on a complicated and high risk medication list, including opioids and benzodiazepines. I'm, taking a harm reduction approach. We know that they've gotten to this point over a long period of time. I'm following the guidelines from ASAM and the CDC around not abruptly discontinuing medications, but I'm going to start a relationship and start some long-term planning to discuss ways to make this both safer and more effective treatment for this patient. And I think including that little blurb or some blurb like that in these notes lets patients see what you're thinking, that you've acknowledged that it's a higher risk situation, that you have a plan for the future, that you're not, just recklessly filling things, but that you're also consistent with the guidelines and that you're not making any abrupt decisions. So next slide. I think we can skip this, and I think Jillian's going to hit some of this, and I think makes good sense to get to case 2. So this is case 2. Jillian, before we go on, did you have? I know Jillian's going to do a lot of talking in the last couple of cases, but do you have thoughts on the first case?
No, a wonderful job, thorough job. I have worked with Dr. Frank on the addiction consult team and in other avenues with Open, and our approaches are similar in creating a safe space for patients to share their information about their pain, but also it's important, and I'll highlight this, just to be genuinely thoughtful and curious about the concerns the patient has, and then quickly in your encounter with them addressing, and reducing their hesitation around getting an opioid prescription, because that is probably going to be at the forefront of their mind. And if we can address and remove that concern and worry early in your patient visit, that can often help open up some brain space for them to retain information about some of the safety concerns that you have, and kind of talking about the etiologies of their pain. And so, and then I just wanted to also reiterate that there's no deadline for completing a taper. There's no award for a doctor for you tapered in 1 year. Good job. There's no gold stars. There's, there is speed is usually not kind of what we're going for. It's slow and steady wins the race with the tapering. So we'll jump into the cases. I know we want to make sure we can get to each case, so we'll spend a little bit less time on these. So let's jump into case 2, Chris.
And I just want to take a stab at maybe I'm saying it right, Marcelina. Marcelina's had a couple of questions in the Q&A. One was, essentially that once you establish rapport, patients are really cooperative when they get the scripts, and they're happy to come and see me as long as I give them scripts, and they're happy every 4 weeks for renewal, but feel like you're robbing them for these visits when they're really not making progress. I think there is a definite difference by how you approach people in the very early phase when you're building relationships, and how you're going to maybe approach this a few months later. If this was my situation and I was 6 months in and this medication list was unchanged, I wouldn't feel good about it. But I also know that, you're going to be very unsuccessful for the most part trying to change it the first time you meet people. So we're really talking today about how you have these effective conversations early on. But the effective communications later on are often a little different. And we'll talk a little bit about motivational interviewing later, but we often focus on functional pain assessments and finding areas where things are not going that well for someone, and using that as an entry point to talk about modifications to the regimen that might have fewer side effects or be more effective for their pain, or doing other things like that. So more to come. Case 2, this one I think only brings up 1 or 2 points that I'd like to make, which is, so this is a 47-year-old woman on opioid therapy, history of chronic pain, and has rheumatoid arthritis, fibromyalgia, has peripheral neuropathy and headaches. So pain in many different body parts. We might call this a central pain type syndrome, right? Where it's not just one thing, it's kind of full body. And the person says, I'm running out of my opioid prescriptions early. So this is someone that you're already seeing, and they're taking hydrocodone, 10 milligrams 4 times a day, and then some adjuncts, ibuprofen, lidocaine patch, gabapentin. They use occasional alcohol, occasional cannabis, but no other prescribed substance use issues. And it's the 3rd month in a row someone's running out of their medications early. I think I initially deleted this line because I feel like the pharmacy never actually contacts me in these situations. But Jillian is a wonderful pharmacist, and if it was her, she would contact me. So we left this in partly to highlight the fact that, if you do have access to an excellent clinical pharmacist or a good relationship with your medication dispensers, this can be invaluable. Essentially, person's running out early, and what do you do? Next slide. And I think, again, there are some considerations for us, and there are considerations on the patient side. This is clearly an area where you need to dig in a little bit, right? You need to ask why, what's going on? What's the person treating? Is their medication making them feel better? Why are they taking more than prescribed? Is it because they're having pain? Is it because they're not able to sleep? Is it because they're having a new pain? And really focusing on function versus pain is one of the key distinguishers, right? So I think a lot of times this is when we might have discussions with people about the difference between acute pain and chronic pain, right? Acute pain, something's injured, your body's giving you a signal that it's injured. Opioids work very well for that. Chronic pain, your body is no longer getting injured, but your brain is still getting the signal that that injury is happening. It's almost a miswiring, right? That the constant signaling that your body is under threat, even when something threatening is not happening. So really focusing on, what people can do, like, when you take your medication, are there things you can do that you can't do when you don't take your medication? How are you able to walk? Are you able to get up? Are you able to interact with your grandkids or your children? All those questions kind of help people refocus on what the goals are. Like that's why I'm taking these medications, so I can go to hang out with my grandkids or do whatever. Those conversations are great. In the back of, I think, all of our clinician minds is, is this patient developing an opioid use disorder? And we know that, some percentage of patients who are on chronic opioids for pain, even when prescribed, will develop an opioid use disorder. And I don't think we have the slide in here this time, but a lot of us use the 4 C's, right? We ask about cravings. We ask if people are having any adverse consequences. So is it causing them side effects or making them sleepy or not able to do other things? Are they ever using more than they intend? So compulsive use. All of these things can be signs that someone's developing a problem. And these tend to be problems that are easier to resolve early rather than later. These can be great times to have some boundary setting discussions around how medications refills work, what your goals are, what you're willing to do, not willing to do. Hopefully this is a point where you've already developed a really good relationship. And so sometimes you can have difficult conversations when there's already a safe relationship that maybe you couldn't have the first time you met someone. And so really sorting out why people are using more. But I will say that one of the common themes you'll probably hear from people who do this a lot is I'm ecstatic anytime something is not going well, because anytime something's not going well, that is the information I'm looking for as my entry to consider making changes. So when someone tells me something's not working well for their pain, or they're not able to do something they want to be able to do, I'm always ready to jump in with I think we should really take a look at this. We should take a look at your medications to see if there's anything we can do that would maybe help you reach your goals, whatever they are. And so obviously to ask them about their goals, you have to kind of ask them about their goals. And that's an important part of it. And these are also ones where you want to carefully document conversations. Maybe I'll just quickly mention the co-use of cannabis or alcohol, because I think all of us are seeing a ton of cannabis. I see a ton of cannabis use disorder in my professional life, and it's just everywhere. So I'll just say that in general, my approach, and maybe I don't know, Jillian's is the exact same, is I treat low risk alcohol and low risk cannabis use as the same. I treat them as things that are suboptimal, but not not surprising. Like lots of people use alcohol and cannabis in low risk ways. But what I'm really trying to suss out are patients who have undiagnosed or unrecognized cannabis use disorders or alcohol use disorders. So people who've lost control of their use and are using in spite of consequences, because in those situations, their risk of developing an opioid use disorder is much, much higher. And the risk of having a couple of substance use disorders together can be really problematic, and often means that we need to reassess our approach and maybe get some other expertise or other substance use disorder treatment engaged. Next slide. And I like this. We'll leave this for people to read afterwards, but just focusing that sometimes it's easy to think that our goals for patients are what matters, and really realizing that really we should be eliciting patients' goals and trying to help them meet their goals, even knowing that their goals will not always align with our goals. Part of autonomy and a free will type situation is that people are allowed to make bad decisions. They're allowed to do things that we don't agree with. And I will say that once I got out of the mindset that everything that someone did was a reflection on my abilities as a clinician, my life got a lot better. And now I try to do my best. I try to help people get to safe regimens that allow them to meet their goals, that improve their function, but really taking the focus off of us as clinicians and keeping it on patients and their goals is, I think, less stressful for clinicians, better for patients, and makes for all around more pleasant work environment and just life in general. So next slide. I think Jillian will probably bring up some motivational interviewing issues in the next couple of cases. So I think I'd like us to go on to case 3. Here we are. Take it away, Jillian.
Awesome. I will also emphasize, I think one of the things that's coming across through these cases, and probably in your own experiences, in your own practices, in clinics, is this overlap of both physical and emotional pain. And I think those are importantly or equally important to address. And you'll see that come through in this case as well. And then, especially in case number 2, where a patient is taking more than prescribed, that, or, refilling early, that's a critical time point. That's a perfect time point for you to jump in and ask some particular questions to open the door to investigate why. Genuinely being curious. Is it increased pain? Was it something that caused an increase in anxiety or stress in their life that may be temporary? And trying to understand what it is about the patient's life that is leading to increased use. Or is it tolerance, right? Is the patient taking more because their current prescribed dose is not relieving their pain? And that's a great segue into having a conversation about what the next steps are in treatment, what the options might be. So in this case number 3, complex persistent opioid dependence in a patient with opioid-induced hyperalgesia. And I'm going to move a little bit quickly so we have time to talk about the fun parts. But this is a 51-year-old man on opioid therapy for chronic pancreatitis with frequent related hospitalizations. So frequent hospitalizations related to the pancreatitis. And their opioid regimen has more than doubled from 5 years ago, and they're missing follow-up appointments simply due to the fact that they're being hospitalized. And so the patient's saying, I can barely work because of the pain. I'm unable to keep down the medication when I get a flare because of the nausea, vomiting, and I have pain everywhere, not just my abdomen. So they have history of alcohol use disorder, DVT on anticoagulation, anxiety, depression. So some things that you may commonly see in patients. And then their medication, so oxycodone 20 milligrams every 3 hours is needed for pain, taking all of the available doses, clonazepam 1 milligram twice a day, pregabalin, and some medication for nausea. No recent alcohol use, maybe some cannabis use, but no other non-prescribed substance use. And so I'm going to go ahead and jump to the next slide of what some next steps might look like for this patient. And so importantly, on multiple of our slides, you'll see functional pain assessment. And there's not one functional pain assessment tool, I would say, that is better than another tool, but I will highlight one that is, I think, fairly well-rounded and it also helps guide patient conversations is the CAPA tool. If you haven't heard of that, it's called the Clinically Aligned Pain Assessment Tool. And this gets not only to, severity of pain, but really understanding, is the pain better or worse than the last time I saw you? How is the pain impacting your ability to do, quality of your activities of daily living, right? So going to get the mail, doing your laundry, things like that. And then it also assesses the pain impact on sleep. And the other components of this is in terms of functional pain assessment is understanding based on that assessment, what are the generators of the pain? What are the etiologies of the pain so that you can have a nice conversation about what medications would be helpful for those types of pain, right? So I think there's sometimes this misunderstanding that opioids are helpful for all types of pain. And that's just not true. And so that is a helpful education point to have with patients in understanding what types of pain would we expect an opioid to be helpful for. And then optimizing non-opioid medications for pain is always important. I know, Chris, on one of your previous slides, you were it highlighted sometimes the availability of those and the feasibility of those is not always conducive or convenient for patients in terms of like non-medication, physical therapy, mindfulness, acupuncture, massage, those kinds of things. And it's worth having a conversation with the patient about. I very distinctly remember another patient with severe lupus-related pain who once we started talking, loved swimming. And the next time I saw that patient, she had restarted swimming, getting in the pool, and that in and of itself, right, is progress, even if there is not necessarily progress on the medication side of things yet. Offering safer alternatives in opioid tapering versus buprenorphine. So this is probably in all of your minds if you're a prescriber is like, okay, at what point is a taper not going well? And at what point am I considering buprenorphine for the patient? And that often stems around the safety of the patient and then also how available routes of administration and readiness for change. And so I think this is oftentimes a conversation that takes place on one visit and then maybe a visit or two later, you're kind of implementing change. And kind of what you said earlier, Chris, about kind of planting the seeds to build on in future visits. And then I will also kind of want to highlight for patient considerations. Sometimes patients, especially in this example, when someone's been on an opioid for a while with increased use and they're discouraged because their medical conditions maybe are worsening, they're spending a lot of time hospitalized and they're not finding as much joy from the parts of their life like work and relationships that they used to, they can get really discouraged and despondent. And I think it is an important point to recognize patients' progress, even the most minute progress, in using that as a stepping stone. And then readiness, timing of change. Consider what's going on in the patient's life. Do they have a big wedding coming up? Do they have some kind of big event coming up? And making sure that the timing makes sense of change with their availability to communicate and connect with you after that visit. So I'll go next slide, please. All right, so these are some example scripts that you can take with you after this presentation to implement in your own practice. Wanted to give you some tidbits of things that have been helpful for me in the past that maybe will work for you in your practice, or you can take and morph and adjust to your specific patient case. But one of the things that helps me understand the patient's pain and their relationship with their opioid is if you were to miss a dose of your opioid medication, what would happen? And just pause. Let the patient think about it and respond and understand. Is it they're feeling uncomfortable, they get agitated? Is it that they're starting to crave another dose? Are they starting to use their opioid for really non-pain related things? And is trying to understand, is the opioid helping with function? So is the opioid working for the patient, or is the patient working for the opioid? Okay, next slide. All right, so I started kind of bringing attention to this, but chronic opioid use does not necessarily mean opioid use disorder. And this is not something that necessarily needs to be teased out, but for more educational purposes. So tolerance is that word that we kind of use when you need increasing dose to provide the same amount of analgesia, while as dependence is kind of more of the physical adverse effects if they were to miss a dose. And oftentimes we think of a dependence as if they experience withdrawal symptoms. So one of the questions, that I mentioned on the previous slide is trying to get at, have you experienced withdrawal if you were to miss a dose because the pharmacy wasn't able to fill it on time, or you went away for a vacation and you forgot your medication? Would you have any physical symptoms that are uncomfortable? And then chronic opioid use and opioid use disorder. So Chris talked about the 4 C's, which is also something that I use when I talk to patients in trying to understand where they are at with their relationship with their opioid, and then highlighting, especially for this patient case, this hyperalgesia component. So this can be an increased response to noxious stimulation. So something that is normally painful is even more painful for that patient. And this is a conversation that I'm frequently having with the chronic pain population, to start inquiring, is the neuromodulation around your long-term opioid use and the process of your pain kind of maladapting? And are we starting to move more towards centralized pain? When someone says they have pain everywhere, not just their abdomen, like in this case, that is a kind of flag that goes off in my brain of, maybe this patient has features that are consistent with centralized pain, in which that is a stepping stone for me to help the patient understand that their opioid may actually be making their pain worse than better at this point. And so that's kind of a shifting point in the conversation. And I want to empower all of you to use that in your own practice as a stepping stone to change the conversation. And Chris, feel free to jump in, but in my experience, this is often received very well for patients, that when you tell them, look, the opioid that you took initially for your pain that was helping your pain is no longer helping for your pain. It actually might be making your pain worse. So let's talk about that. Would you mind if I share some information with you about what I know about that?
I was just going to say, I feel like this is like the light switch goes on sometimes for people with this conversation, because, almost everybody who started an opioid was getting benefit at some point, or they wouldn't have continued. And oftentimes it's gone on for a long time, and people maybe don't even remember what it feels like to be non-medicated. But they can get to this point where they're like, obviously, this is not working. Like, you're in and out of the hospital all the time, or you're continually, in pain so much that you can't participate in daily activities. And the idea that maybe, there's another explanation can be very, very powerful for people. And like, not only like an explanation, but like a next logical step, like for people who maybe feel like they have exhausted everything. They've tried everything, but like what they actually haven't tried probably is decreasing their opioids.
Yep. And oftentimes patients, when I talk to them about centralized pain and hyperalgesia, and that likely, with dependence, their pain is actually worsening now, and highlighting that is really validating to the patient, because patients are a little bit confused. Why is it all of a sudden not working? Many a times have we tapered opioids or transitioned to buprenorphine as a safer alternative in terms of like harm reduction. And the patient has come back. I've gotten letters from patients in the mail saying, "Oh my goodness, this is like a weight off my shoulders. I can do things that I wasn't able to do before, and my mood has changed." And that's always so rewarding. I'll go ahead, next slide. So I won't dive into the nitty gritty of this, but I do want to highlight some of the terminology around opioid dependence. And these three are kind of the three main categories, which is complex persistent opioid dependence. You'll hear more in the literature. It's called CPOD. This is a gradually develops, but this is a core of the patients who are on chronic long-term opioid therapy, who have signs of dependence and may start having features that are consistent with hyperalgesia, and oftentimes decreased function with worsening pain control. And then non-medical opioid use, this was kind of our second case. So maybe they have an unhealthy relationship with opioids, maybe not yet, but the patient perceives the opioids to continue to be beneficial. And then opioid use disorder, we talked about the 4 C's around that. Go ahead, next slide. All right, patient-centered communication and tapering. So patients, there's not one taper plan that is a one-size-fits-all. It generally, here is some guidance on this slide, by decreasing the total oral morphine equivalent by about 10%, every week to up to every 4 weeks. Oftentimes we find that, about a 10% decrease for the first several months is feasible. But once patients get to those last, 3 doses a day, smaller 3 doses a day, et cetera, it's harder. It's harder to really at the very end, because that 10% decrease, when you decrease, oxycodone 10 milligrams from 3 times a day to 2 times a day, that's about 30% decrease, right? Not just a 10% decrease. And so at the end, do not be surprised if it's more challenging than in the beginning. And then a slower course may work better, and pauses in the taper may be needed. Or if the patient is experiencing uncomfortable symptoms and you've educated them on that and they're not tolerable, taking a step back, pausing, and then restarting even slower. Go ahead, next slide. All right, let's jump into case 4. I guess before I jump into case 4, Chris, do you have anything to add on for a patient? Okay. So case 4, this is a 72-year-old man on opioid therapy for pain related to non-small cell lung cancer, now in remission for 3 years, which is fantastic news. The patient comes in and kind of says, "Can you increase my morphine? My knee pain is just bothering me so much lately." And on their problem list, they have chronic kidney disease, hypertension, arthritis, and a history of tobacco dependence. And medications include a long-acting morphine, 60 milligrams twice a day, with immediate-release morphine, 30 milligrams every 4 hours, Tylenol, and alprazolam, 1 milligram 3 times a day. No alcohol use or non-prescribed substances. You notice with the information you have available to you, which is not always the case, but you notice that there seems to be adherence with visits and refill requests. The prescription drug monitoring program is consistent with the report, and urine drug testing is consistent as well. I'll go ahead, next slide. Okay, let's jump into this. So in this case, so this patient had a diagnosis that was likely treated with an opioid and maybe that benzo as well. And now that is in remission and they're still on these medications, they're kind of talking and meeting with you, but they also have knee pain, okay? And so the first thing on this list to consider are the etiologies of the pain. Is knee pain responsive to opioid therapy? Right? Okay, just pause there. That's part of what we need to find out. Unlikely, if it's this arthritis, there's probably a different avenue and mechanism. However, I will point out, right, the patient's experience with knee pain is probably elevated, or they may have an escalated response to pain simply because of the longer term opioid regimen that they're exposed to. And that is maybe hyperalgesia, maybe not. I think that's part of the assessment that would need to be done. But I think an important takeaway is anyone on chronic opioid therapy who has maybe a new or increased level of pain, that is not unexpected, right? I expect my patients, post-operatively or after they've had a surgery, to have elevated response to pain that patients who don't have that opioid exposure would have. And so age and patient characteristics are also important to talk about with the patient. So likely as patients are getting older, they may be on more medications. More medications offer the opportunity for more drug interactions. My pharmacist brain going off. And then as well as they may have decreased metabolism. So their liver may not be processing the medications the same as they used to when they started that medication. And that can increase the patient's risk for opioid-related adverse effects, particularly when they're on, multiple CNS depressants. And so framing that in a way that is digestible to the patient can sometimes look like, hey, look, your body is a little bit different now than when you first started taking the opioid medications. Let's talk about that. And then indications for opioid and benzodiazepine therapy. This is challenging, right? I'm sure, Chris, you could jump in as well. But I will say I am typically not recommending tapering both of those medications at the exact same time. Usually it's working on one before the other and having a conversation with the patient to tease out what is feasible to work on first, and or which one is posing the highest risk to the patient. Are they taking all of those doses? Are they taking them together? Are they taking one more for sleep, and trying to tease out what their day looks like in relation to those medications? And then the anticipated trajectory of diagnosis, prognosis. Sometimes patients are right and they're seeing you in the midst of a new medical diagnosis. In this case, the patient's in remission. And so I think that it brings a positive light to start a conversation of like, wow, that is fantastic news. And let's work on kind of reducing opioids that aren't helpful for the type of pain you're having and optimizing the things that are helpful for the type of pain that you're experiencing in your knee. So patient considerations, shared decision-making. So almost always I'm offering patients, like, look, this is what I'm thinking. You could do this or this. Like, what are your thoughts? And offering them a safe space to kind of share their hesitations. And if they are coming with some resistance, it is your job to kind of understand why. What are their hesitations? Because if you can address that, oftentimes it's just a gap in understanding or gap in knowledge in either your understanding of the patient's experience or the patient's understanding in how the medication or the pain is working in their body. And then goals and quality of life. This is always at the forefront. I like to highlight things that the patient is able to do now as we start addressing their pain, or things that they want to be able to do, and documenting that in my progress note so I could touch on that in subsequent visits. Prescription insurance. Keep this in mind. Sometimes when we're changing therapies, decreasing dosing frequencies, we have to be mindful about what the insurance is going to cover, and if that is a feasible formulation or an available formulation at the pharmacy. And so expecting good, communication with the pharmacy and telling the patient if the pharmacy isn't used to stocking this for you, it means that it could take up to 2 or 3 days for them to get that medication in. And so keeping that in mind and how you prescribe the medication, so that they're not going without. And then previous experiences adjusting and tapering opioid therapy is important. If you've had patients who have struggled in the past, understand why. Understand what their perspective is on what went well, what didn't go so well, to help inform how this tapering and or this transition to a buprenorphine, for example, can be more successful. So I'll pause there and let Chris jump in as well on case number 4.
No, I think that's great. I also would encourage people. We haven't touched on it. We haven't talked about buprenorphine much today, but buprenorphine brand name Suboxone, but there are other brand names of formulations that are FDA approved for pain. So Butrans would be like a transdermal patch that you might have heard of, and there's a generic version of it too. And I think many of us in these more complicated situations, we often try tapering first to see if it's hyperalgesia related, see if people get a functional improvement from decreasing their opioids. But if they're not able to decrease their opioids, often we'll try to switch them to something that's safer, like buprenorphine, has fewer risks, and seems to have less of some of these hyperalgesia type effects. So oftentimes we can kind of thread the needle, safer and more effective. And oftentimes, I guess I don't really find the safer message to be extremely effective for lots of patients, but the more effective one, that it works better for pain is very effective, is to get people to try it. And so I think I would agree with Jillian, just like, baby steps, any progress is success. And I think shared decision-making that focuses on patient goals and quality of life is the way to be.
Go ahead, next slide. And this is some examples of conversations you might have around case number 4 as an example, but kind of highlighting the changes that your body is different now than it used to, especially in the aging population, to use that as a jumping off point. I know Chris and I were kind of talking about keeping a close ear out for things that aren't going well, and changes from previous visits, and jumping off, using those as jumping off points for your conversation. And then also, I won't read these all the way through, but it's completely normal to revise your taper plan based on the patient experience. In fact, I expect this. And so offering that to the patient early in the tapering process can be a little bit of relieve some apprehension of the patient. And then your pain is real, and I want to help you in a safe way. So safety is also a key of the conversations to help move forward, and to have some of those conversation points that you can really rely on when you go into these visits. Go ahead, next slide. So take home points. Start with open-ended questions. Listen to the responses. Go ahead, next slide. And then chronic pain. It's a common problem affecting nearly a third of Americans. Effective communication strategies can be therapeutic. If you take away anything from this presentation, I hope that it empowers you to have those difficult conversations with patients, and approaching them with a patient-centered focus and allowing them a safe place, with the goal of it is not a race, and it likely the patient will have improved outcomes when we can have a quality conversation with them from the beginning, and then address concerns in using changes in pain to direct how we talk about the opioid with the patient. So we're going to open up to Q&A.
Jillian and Chris, thank you so much. That was a bit of a whirlwind, lots of information, but I think a lot of it very actionable for the providers on the call. Let me take a quick peek at the Q&A. I see the the two questions that I think Chris already answered. If anybody has a question, you have about 2 minutes to type it in. I had some questions about the stigma around buprenorphine and how do you talk to patients. I've had a couple of patients say, oh, buprenorphine is just for addicts, and I'm not an addict. So that's not a good medication for me. Have you encountered this? And how do you address that? Maybe while we let our audience think if they have any questions.
I think Jillian and I both had this talk a lot. And I think it actually has gotten easier now. The way I start with it is that actually buprenorphine was originally designed for pain. And then we found out that it worked well for opioid use disorder. And it used to be a more fraught conversation because the only formulation that was really available that we could get covered by insurance was Suboxone, which, is mostly used for opioid use disorder, works for pain also at a different dose, but can be very effective. I think the pain formulations that are available now have really opened up the conversation because we can say now, actually, there are kinds of buprenorphine that are only approved for pain. And those may or may not be covered by your insurance, but you should know that this medication has two big categories where it works: opioid use disorder and chronic pain. And so you shouldn't feel, that was an old way of looking at it, that this was only for people with substance use disorders, and that now we have this whole new pathway for treatment.
Fantastic. Thank you so much. We are at time, and I don't see any Q&A questions popping up. I do invite our audience to let Jill Solomon know if a question pops into your head at a later point. We will forward it to our speakers or answer it directly. As I mentioned at the beginning, you're going to get a survey at the end of this session in just a short while, inviting you to fill out an evaluation and claim CME credit. And then we will be announcing future sessions. Our website has just been redesigned and retooled. There are a lot of fantastic resources for you with regards to training yourself for free or paid courses. The toolkit is being redesigned. Some of it has already been redesigned and is redeployed with updated resources and a very nice kind of user-friendly interface. It's a lot less flat than it was previously. And again, as with previous webinars, we will be sharing the slides with all of you. So again, thank you so much for your attention. Thank you, Chris and Jillian, for this fantastic conversation. We appreciate you so much. And with that, I will say, have a great day. It's supposed to be beautiful today, so enjoy the good weather. Take care, everybody. Bye-bye.